Yeah, yeah. Thanks everyone for coming, and I would like to thank Hetero for arranging this meeting. Today, I'll be presenting two cases, and both cases the patients have pulmonary hypertension. Okay, so I'll start with case one. The 35-year-old female patient under treatment with physician for headache since last 3 years, and now she was admitted in General Hospital, YCM Hospital. She was having diagnosed migraine, getting treatment with physician. And now she was admitted with massive ascites. Sorry, huge ascites, then hepatitis, pleural effusion since last 1 month. And now she referred to me in view of ANA positive status. Next. Yes. I'm seeing him for the first time. Phone worthy was. Anyways, so on examination, she was emaciated, thin built. Her weight was 38, and so all other parameters were okay. Her respiratory was almost 32 per minute, and saturation was around 96%. She was on NIV and with 70% FiO2. And on examination, she had pallor and pedal edema. Next. So on examination, she had erythematous rash over face, nose, and hands. And on abdominal examination, she had gross ascites. And on respiratory examination, their entry was decreased on left side, on right side. And on CVC examination, she had loud P2. Next. Next. Yeah, and she's the patient where you can see the erythematous rash over nose. She had some ulcers over lips, and she had these erythematous rashes on hands also, and gross pedal edema, which was pitting on pressure. Next. So, on further investigation, her WBC on platelet count were fine, but she had anemia of 6.5 hemoglobin, and ESR was 56, CRP was 26. Her liver enzymes were slightly raised, 160 and 240, AGOT and PT, and she had hypoalbuminemia. Albumin was 2.8, and urine showed 1 plus proteins, and all triple H were negative. Next, HIV HBC antigens. And so, yes, so looking at the scenarios sent this CTD panel, so ANA turned out to be positive with high titers, 3 plus speckled, and on ENA she had multiple antibodies, and complement levels were low, and urine PC ratio was for 450 milligrams. And so keeping this autoimmune hepatitis in mind, because liver enzymes were raised, I asked for anti-LCM and asthma, so both were negative. And UHG abdomen showed gross ascites with liver parenchymal disease, and CT was again consistent with this. And X-ray showed massive pleural effusion on right side. And 2D echo showed severe pulmonary hypertension of 78 millimeters of mercury. And on 2D echo, RA and RV both were dilated. So kept the diagnosis with lupus with ascites, pleural effusion, severe pulmonary hypertension. So all these symptoms, whether they were because of secondary means secondary symptoms, all secondary signs and symptoms due to right side heart failure or primary liver parenchymal disease. And so to CPK was not done. So ascites was tapped, and so it was lymphocytic predominant, and so pleural fluid ascitic fluid ADA was negative. So patient was started on HCQS, calcium channel blockers in view of severe pulmonary hypertension, tadalafil, and ambrisentan. So pulse steroid was given, and for 3 days, and then followed by 1 mg per kg oral steroid. Diuretics were given, folic acid, vitamin D, and iron. So condition did not improve. So decided to give. So since the condition did not improve, I was just thinking what should be the next step. So decided to give either cyclophosphamide or rituximab. But since patient was not affording for rituximab, decided to go with cyclophosphamide NIH regimen. So first cycle was given with consent because young patient was there. So after 3 weeks, after giving cyclophosphamide, 3 weeks, she developed a fever for almost a week, and fever was to be used to be around 102 and 103 per night daily. And CRP, yeah, next, next, yeah. So she developed fever after 3 weeks, and then CRP went to for 54, ESR was 108. So raised parameters were fine, but now on examination we could find that the patient had sauce abscess. It was almost 8 into 10 centimeter. So pulse drained from the sauce abscess, and TBGN expert sent, and culture sensitivity was also sent. And next slide. So on examination there was caseation and AFB was seen on these pulse, and TBGN expert, it came to be positive, but there was no resistance. So patient was started on ATT, and after 2 weeks of this treatment, 4 drug ATT, patient developed jaundice and LFTs. LFTs were deranged. So this time the patient had severe jaundice. The bilirubin went up to 11.6. SGOT and PT were markedly raised above 600. So the typical diagnosis of ATT-induced hepatitis was put, and then patient was given hepatosafe ATT as per the gastroenterologist and pulmonologist. Next. Yeah, wait. So here the question was, since her disease activity, lupus disease activity was still persistent, so should I go with next cyclophosphamide or not? That was my question, because she, yes, yeah, but then still she was still on NIV after 3 weeks. Cyclos. Yes, yes, which were already started. Yes.
Whether this hepatitis is secondary to right heart failure,
Yes.
or it's all, or it is actual parenchymal
Yes.
involvement. Looking at all this situation,
Maybe
safe
disseminated tuberculosis.
just treat it like pulmonary hypertension,
Yes.
the vasodilator.
Yes.
Then it's a difficult for manage.
Yeah.
Apart from pulmonary hypertension, she only had sinusitis.
That
That's
also
what you are-
possibly secondary
And
to right heart failure.
right.
So everything was right heart
So
failure.
when I saw her first time, I thought of right heart failure only. But then why this liver parenchymal disease and liver enzyme? Again, secondary to heart failure,
Right,
not
heart
ischemic, we call it.
Correct.
Yes.
Congestive rather than ischemic. It is very probably
Congestive
rather
heart
than
failure.
Yes, yes. I was thinking in terms of that.
So at the moment, I don't think she requires any immunosuppressive.
Yes. 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 Yes.
And just
So she was already on diuretics.
So just withdraw the immunosuppression.
Yeah, but in that dilemma, we gave second dose of cyclophosphamide. Later, I did not give. Yes, but after 3 weeks, she developed 3-4 cold abscesses over knee. Yes, yes. And drained and sent for culture sensitivity and TBGN expert. Again, and her LFTs eventually became normal. They were all these liver parameters were becoming normal. SGOT-PT was settling down, and discussed with chest physician and gave a continued hepatosafe ATT.
I've just negotiated on IM. Their disease activity has also reduced. in fact, in fact, whatever was planned, this has happened. Even one patient today. No.
Yeah, but on presentation, she had some severe lupus symptoms, like severe oral mucositis she had, then complement levels. So, yes, not severe, yeah. 500, yeah, 450.
It was only 500.
Yes,
So it was mucocutaneous,
Yes,
probable serositis.
yes, yes.
That was the only
Yes, and
lupus
pulmonary
feature.
hypertension. Yeah, Apple was done. It was done, yes.
Otherwise, pulmonary hypertension as such is vasculopathy. And therein, as you was pointing out, immunosuppression is not required that We have to just target for based on.
So I'm going to show that.
Two of, I don't remember the exact how breakup was there, but only those who were proven lupus, full blown lupus, only they respond to
Yes,
immunosuppression.
yes,
Rest nobody responds. In fact, they deteriorate.
yes, yes.
So your
And
time.
yes, you're absolutely right. And all the studies which were done with these immunosuppressants, they were before 2010, when vasodilators were not developed.
This is a tricky area.
Yes,
Some rheumatologists have burned their hand and they're fighting a case in the court.
yes,
I'll tell you later.
yes.
Based on this issue.
Vascular.
They have DLC. They
No,
have DLC of exclusion.
yes, different end. Yes. Okay, so for
And
minimum for lupus,
according to the cardiologist or physician who would be helping you out with treatment, what is the minimum timeline for response of our right-sided failure with pulmonary artery hypertension of that
2 to 3
intensity
months. Generally 2 months.
so 3 weeks of NIV is still not to be classified as refractory.
Yes,
It is still within expectant line of treatment, duration of treatment.
yes,
In fact, that makes your life
yes. Yes, just 2 doses given. Then later we did not give it. Yeah, because there was slight confusion whether the disease activity is there. Then switch. Then patient was switched to MMF and next, next, next. Yeah. So the patient was switched to MMF and steroids were rapidly tapered off. And the patient continued with other treatment, calcium channel blockers, tadalafine and HCQS. Apply workup by the time came negative. So after 1 month, patient's this cold abscess is almost completely gone. Just small swelling was there. She got stabilized, and repeat ultrasound showed mild ascites. And now this time the liver parenchyma became normal. And so chest X-ray suggested a mild effusion. And 2D echo showed PSP grossly decreased. It was 16 millimeters of mercury. So within 3 months, 3.5 months, everything became normal. So what was the episode? Whether it was just right side heart failure? Next. No, no, it's a cold abscesses, healed cold abscess. Yeah. So whether it was complete reversal of pulmonary hypertension, which was because of, yeah, yeah, I'll show. It was just showing some lymphocytes. 300 cells were there. It was transient. Yes. Yeah. But multiple antibodies, low complement levels. It is like lupus funny. Okay, so what was the thing? Means whether all these liver parenchyma and everything became normal. So whether it was just a congestive heart failure, right side heart failure. Next. Yes. So next case is also same, little same. Okay, well, or was it a lupus hepatitis? Recently, I saw one patient, the patient of lupus, coming like severe this liver parenchymal disease, hepatitis, pulmonary. So in lupus,
Is chronic thromboembolism. Okay. In itself, usually it's in overlap syndromes. like scleroderma we can understand.
Yes, and
But
limited
reversal
scleroderma-
is very surprising. In fact,
But
okay.
when I saw
So-
her for the first time, things were like this. So what
Huh.
could be the other reason?
So D dimer or any other things you had ever
They were
done?
fine.
They were fine.
Yes.
Check.
It was done when they did the CT abdomen. It was also normal. Yes.
But it was severe.
Severe. Yes.
Yes. So any drug induced effect you can.
Yeah. So that is the only exception. And I forgot to show the rashes also. She had typical erythematous rashes on hands. But how it will present just like lupus? All these erythematous rashes, mucositis,
See,
both together. Yes.
of course, it was triggered. Lupus was triggered by infection. So only thing that remains unexplained is pulmonary.
And how it suddenly
And
reversed.
because you have to think about pathophysiology.
Yes.
It is entirely different.
Yes. Yes. Triple red. Mycophenolate. Just 1 gram now. Hey, it was not there. No.
Cardiographic measurements tend to overestimate pulmonary hypertension severity, but we cannot attribute that to only overestimation because she had signs of right heart failure also. So it was there and it was significant, which has improved. The second thing is there's something called portopulmonary hypertension. Whenever there is hepatitis or portal hypertension, there is reactionary pulmonary hypertension, which usually settles with treatment of portal hypertension.
Seeing what lupus vulgaris is, if we had done any skin biopsy anywhere, that could have helped, like sometimes, if it's all tuberculosis.
All physicians treating everybody with AKT.
For lupus.
Suppression is a question. Whether it needs to be treated.
Yeah, so eventually the time will tell us. But anyways, my plan is to taper MMF if she's doing fine. Anyway, she's off steroids now. And she's on ATD.
I don't understand the rationale of giving her MMF because I feel that cyclophosphamide and MMF have almost same uh, efficacy and
But sir, MMF
similar
dose
risk.
is dose you can use from 500 milligrams to 3 grams.
I understand. So the risk is same.
But we'll have to give something for lupus. Yeah. But I decided it is lupus. I'll show you some images here. They are on my phone, the hand images. Yeah. Yeah. So next case, 34 years female. She was under treatment with some Ayurvedic doctor for breathlessness for 4 years. And now she was referred to me by a physician because she had severe breathlessness, NYHA grade 3 to 4. And the breathlessness was so severe that she had difficulty in talking and she could not do household activities also. So there was no other complaint. And this time she was referred because ANA was positive. So on examination, her pulse was 108, respiratory was 28. She had loud P2 again. And so other systemic examination and MSK examination, I could not find anything. But she gave me a history of Raynaud's plus minus. And so I could not elicit anything, any bluish discoloration or whitish discoloration of fingers. So investigated further. HB was slightly less. TLC and platelet count were normal. LFTs were normal. So ESR was 45. So again, CRP was 17. So there was no any abnormality here. But again, when I asked for the X-ray, X-ray showed mild cardiomegaly. And since the P2 was loud and she gave history of this breathlessness, asked for 2D echo. Now this time 2D echo showed severe RA-RV dilatation with PASP of 84. And ejection fraction was 50%. So asked for pro BNP and it was 250. And so considering all these parameters, sent for ANA and ENA, so both came positive. And 6-minute walk test, she could not elicit. So she could just walk for 250 meters. And after that, she developed severe tachycardia. So she so diagnosed with MCTD with secondary pulmonary hypertension. So yeah. Yes. Mm. And she was getting treatment for 4 years with Ayurvedic doctor. So diagnosed with MCTD with secondary pulmonary hypertension. So treatment started HCQS, folic acid, vitamin D, tadalafil, 10 mg, and then 20 milligrams, amlodipine and ambrisentan, 5 milligrams. So here I did not give any immunosuppression because there is no role. So now the patient responded beautifully. You can see on left side, the X-ray is on presentation where the right ventricle is little dilated. The patient had cardiomegaly. And after 3 months, there is marked regression in cardiomegaly. And today echo showed, again, the pulmonary arterial hypertension reduced to 25 millimeters of mercury after 3 months of treatment. Again, triple combination, amlodipine, tadalafil, and ambrisentan. So on follow-up visit, she was doing well. After 1 year, she came with leukopenia, 3 to 4 episodes she had. Then TLC was between 2,800 and 3,000. So gave short course of steroids and mycophenolate again started because of leukopenia this time. And lost follow-up for 8 months later. So now after 8 months, she came with severe breathlessness, dyspnea grade 4, fever on and off, fatigue, and swelling in the legs. So this time investigated. Next. Yeah, HB was slightly less, 8.8. TLC was 3,200. ESR was 96. CRP was 16. And 2D echo, again, the PA pressure went up to 78 millimeters. Pro BNP was raised again. So typical defaulter, but now she's playing with her life and she came with severe pulmonary hypertension. So this time, because of the persistent leukopenia, decided to give mycophenolate 2 grams and steroid short course, HCQS, folic acid, continued with tadalafil, amlodipine, and ambrisentan again. And after 2 months she came, but there was not much relief. Slightly dyspnea, it went to grade 3, but still she had fatigue. And this time 2D echo did not improve much. The PA pressure was just 64 millimeters of mercury. So what it could be? So I thought of secondary APLA. So APLA workup was negative. Thought of this pulmonary thromboembolism. So again, that also came negative. So what should be the next step now? Yes. Yeah. Yes. So I escalated the doses. Next. So increase ambrisentan to 10 mg and tadalafil 40 milligrams and amlodipine 10 milligrams. This time I added valsartan. I'll show the paper of valsartan working. I'm coming to that point. Yeah. So increase the doses of all medicines, and this time after 2 months, dyspnea settled. She is able to do all activities, and again 2D echo was again reversed. So this is second case where 2D echo was reversed, and PASP was 22 millimeters. So, but if she defaults or if the PSP worsens again, then what should be the next step? Previous. She had leukopenia and fatigue fever. So we dose double kele. Ambrisentan was 5 milligrams, and the tadalafil was 20 milligrams, and amlodipine was 5 milligrams. So this is as per ambition trial. I'll show the trial now. And valsartan added because there are 2-3 papers which show that in COPD, patient with COPD having secondary pulmonary hypertension, it works beautifully. There are few papers. Yes, even I showed the X-ray. X-ray was, it became almost normal later. Next. Yes, that's it. So all of us know this, that these are the 3 targets: endothelin pathway, nitric oxide pathway, and prostacyclin pathway. Next. Yeah. So this is the pathogenesis where the normal pulmonary artery has some inflammation because of some trigger, maybe the viral infection or any other trigger, which causes the influx of cytokines and chemokines, and so recruitment of inflammatory cells, which causes vascular remodeling in situ thrombosis and the matrix remodeling, eventually pulmonary hypertension. Next. So these are the bad prognostic factors. So pulmonary artery pressure more than 40, DLCO less than 55% than predicted, FVC to DLCO ratio more than 1.6, and exercise induced hypoxemia. Next. So when you suspect, all of you know, if the patient has exertional dyspnea, elevated pro-BNP, and hyperuricemia, and FVC to DLCO ratio 1.4 to 1.6, more than 1.4. Next. Yeah, so the detect study, so it was multi-center, multinational study, where they tried to find out which patient should be asked for right heart catheterization. So these are 2 steps, and they have developed app also. So you can download it from Google. So these two steps, they have different parameters. Next. Yeah. So step 1, these are non-eco variables where they try to get this FVC and the DLCO ratio. Then they try to see whether the patient has any telangiectasia, ECG right axis deviation, and pro-BNP and uric acid levels. So if the total risk score is more than 300, then they go for 2D echo. And if again there are few parameters in 2D echo, right atrial area and TR velocity. And if it is more than 35, the total risk score, then go for right heart catheterization. It's really difficult to ask in India for the to patient whether to go for right heart catheterization. But why to go for right heart catheterization? Because you can miss 29 to 30% patients with severe pulmonary hypertension. But if you follow this algorithm, only 4% chance of missing out pulmonary hypertension. If transthoracic is showing above 40 millimeters of
the pH has been established.
yes, then you can institute the treatment. Next. Yes. We used to read it in Harrison. Next. So this is the treatment algorithm. So general measures like the patient should be asked for breathing exercises, supportive therapy, and try to get whether the patient fits in functional class 2 and 3. If 2 and 3, you can try monotherapy or straight away combination therapy. And high risk, we don't use parenteral here. So you can, the best option is using double or triple sequential therapy. Next. So all of you are aware of this. Next. Yeah, so these are few trials. So Messi was the first. This trial was done in 2013, where next, yeah, they got these 750 patients, 740 patients, and they give. This was again double control trial, where they one third patients were given placebo, one third were given 3 millimeters, 3 mg, and one third were given 10 mg Messi. So the end result was worsening of pulmonary hypertension, and on the basis of 6 minutes walk test and 2D echo showing increase in pulmonary hypertension. So it showed a significant reduction in pulmonary hypertension at the end of 3 months. Next. So you can use any of these combination therapy. Next. Yeah. So this was a trial I was talking about, the ambition trial, where they used um, uh, these all this ambrisentan, tadalafil were used in double. All doses were used in double. So again, there was significant reduction in pulmonary hypertension. So here the uh, the trials end results were significant. So the mortality was significantly reduced. Next. So these are few trials on bosentan and other ambrisentan trials. Next. Yes. So the previous one. Yes. They have done some prostacyclin trials also. The first one, ipoprostinol trial, they used IV ipoprostinol for 6 weeks, putting some IV lines. So they again showed significant improvement, but it is really cumbersome. It is really difficult to carry these IV lines and center lines. Next. Yeah, so this is a newer molecule, the oral PGI2 receptor agonist. So in this Griffon trial, the patient was randomized 1:1. So out of these 1200, 1156, 34 patients had CTD. And so they randomized 1:1, like half patient were given placebo and half patient were given selexipag. So the primary endpoint was composite death, complications related to PAH, whichever occurred first. So that was end of the treatment. And so treatment with selexipag showed almost a 40% reduction in primary endpoint. Yes, it was in addition to tadalafil and ambrisentan, double net combination. I don't think. PGI2. Next. Yeah, we can use. Yes. Yes. Now nowadays we use ambrisentan more than bosentan. Yes. Yeah, it has been used, but it has been used. There was one trial of bosentan. Yes. And this selexipag is almost 3,500 rupees therapy for a month. Never, I have not used it yet. Yes. Then I have not used it to practice. So it is effective because all these PGI analogs. Yes, it is. Hmm. Yes. Better. You should treat aggressively.
Then we don't know whether the contribution by CTD per se is more than fibrosis. So if the contribution by yes, that is more of problem with COPD, where there is hypoxic pulmonary vasoconstriction in areas which are relatively less ventilated. That actually worsens the VQ mismatch, and initially the patients may have hypoxia and hypercapnia, which is worsening. But once they adapt to that initial phase of 1 to 2 weeks with new homeostasis, the long-term benefits by decreasing the remodeling of the right ventricle, thereby preventing long-term right ventricular failure, they slightly outweigh the benefit, the risks initially. But yes, they have to be given under very controlled trial, and you have to accept some worsening initially. Unless we are geared for that, I don't think we should try. But there is no blanket recommendation for using PA specific therapy for patients with obstructive airway disease, not yet.
But this trial, it has shown combination, dual combination. With, so this is the paper which showed the importance of quads. Yes,
It has become available.
the same guy,
Last
the
3 or
Ganesh
6
who
months.
Cipla guy provides the same medicine. Yeah. So next, cyclophosphamide in PH. So there are two papers. This one is Japanese paper which showed that they studied 5 patients where they used cyclophosphamide in, especially in a lupus, and these 23 patients were used. The CYP used in 23 patients. So again, these are few trials next where they use cyclophosphamide in lupus patients. So all showed significant improvement, but they should be always given with vasodilatation. And steroids, so one small paper I got this, so they included 5 patients, so they did not get much benefit. They gave short course steroids, but they did not get much benefit. So again, the role of steroid is questionable. So treatment should be initiated as early as possible as PH diagnosed. So all CTDs, PH is bleeding cause. So all you are aware of this. Always start with combination therapy, and right heart catheter should be considered using detect PH algorithm. Thank you. So that is a big question. So sir, I'll answer this. Yeah. So if you go by the mechanism of HCQS, it works in lupus. So as per Malviya sir said, you should give it in even systemic sclerosis because the mechanism is more or less same, and anyway HCQS has no harm, so it doesn't cause any harm. So that thrombotic.
Why I would say is if you have comorbidities and if you have clinical signs of lupus, okay, maybe whatever clinical signs, there are many benefits. In fact, recently what had happened is for rheumatoid arthritis, I have stopped using HCQS too much. I just use methotrexate and this. And one of Godbole, one of my patient with diabetes, he also shows a endocrinologist, Dr. Godbole. He started 400 mg and all that. Even
400
200
TDS.
200
Huh?
TDS I have seen. Hey, Sanjay Agarwal and all. And in fact, I was like, okay, your disease is controlled, you don't need it. And I discontinued it. Next time that patient came back to me with a angry reply from Dr. Godbole. This is not for your RA. So just
It
shut
has
up.
very good effect on in controlling sugars, even lipids, everything.
Yeah, so endothelial dysfunction it helps, but actually it is being misused. That
This
we
high
have
dose,
to
we should not use it.
no, no. antithrombotic. It stabilizes lipids. There are data. It's not a problem.
Yes. Even lipids.
It's not a drug without evidence, it's a drug with evidence. So can't necessarily see that it's over abused.
Lupus, yes.
Pleiotropic effect, yes. Probably disease modification, low.
But sir, in RA also, it gives good boost to methotrexate. So there are papers which say that HCQS improves methotrexate activity.
Actually, I have recently observed a case in which, I withdrew its hydroxychloroquine after about 4 or 5 years of RA treatment, and within 6 months that patient developed flare. Of course, that could be because of other causes also, but uh, I was just I was a bit surprised that whether that withdrawal of hydroxychloroquine has led to this particular flare.
So that is one problem. Yes.
They get very upset when
Yes,
they
yes,
get tan. It happens after 6 months, 1 year or so. Then when they ask, you have to tell it's because of this. So
Yes,
they
yes.
said band karo. So and now we have many options. So I also withdraw in RA after. No. It is lupus. So you have to give.
You have no choice in
नहीं,
lupus.
lupus नहीं. Yeah. No. We
True,
are not
true.
talking about lupus here.
Yes, yes. So,
Lupus, I never discontinue. Yeah. I'm
yes,
talking
yes.
about rheumatoid arthritis.
So what are you saying? Absolutely, that's the reason to give HCQS everywhere.
Yeah. Driven.
Real autoimmune disease. Yeah. Yes, yes. Yes, yes.
No, lupus, there is no doubt only. I'm just talking a practical complaint which relatives
Sir,
have.
even in scleroderma. Yes. I'll show the paper, sir, on scleroderma.
But it has equal efficacy as far as any driven disorder, independent of that. For pleiotropic, yes, that's also for pleiotropic, yes, and in rheumatoid, only methotrexate versus methotrexate with sulfasalazine with hydroxychloroquine, it has certainly scored better.
But HCQS is better than sulfasalazine in methodex.
And also reduces the hepatic toxicity. There are
Yes,
I'm happy that you are concurring what I'm trying to say. So that's exactly what I'm trying to comment. That hydroxychloroquine is an important part of armamentarium, even in rheumatoid.
Shown benefit about mortality outside.
In rheumatoid, it has shown better response vis-a-vis methotrexate mono. So I didn't comment on morbidity and mortality in rheumatoid. It was only about disease response to DMARDs. If the response of triple DMARD is at par with biologics at end of 2 years, I think the data itself speaks for itself. They have brought it at par with metformin, where it's pre-diabetic is where you initiate hydroxychloroquine or metformin. Yeah.
This is definitely diabetic sickness. And you stop the antidiabetic.
I have one very different thought in mind that if uh, 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 if hyperglycemia is a part of that immune dysfunction, if at all, hyperglycemia is the part of that particular immune dysfunction, which we are controlling by way of by way of adequate treatment of RA, then the sugars will automatically get control. The same thing happens with thyroid uh, thyroid status also. Initial requirement of 100 micrograms, then 75, then 50 micrograms, and so on and so forth. So,
So better control of the background connective tissue disorder would lead to better control of metabolic dysfunction.
yes.
For HCQS, we don't. It's just about better control of the disease.
This can also be taken. Anirudh, this can also be taken. That must be very big.
Because we are not doing formal introduction for it. You are one of us now.
So probably now you can use enough time.
Many more waiting online.
The important ones are here.
No, it is online too, so there are so many people there.
He carries a lament that in the MRI con we have to cut him short. So now probably.
I carry the other way around. I never took my time. That is what I carry.
So these are giving way back to again to utilize nothing.
Many people are online. Oh, good. 6 online.
Yes, loads.
So 6 plus 6.
Can you spend a easy meal?
There is no holding a workshop. चौबीस से 27
Thursday. Thursday.
काय वर्कशॉप काय वर्कशॉप
You're not excluding many people there. You can just take it.
तारीख है
Thursday.
गुरुवार है
पांच speakers. एक US.
Okay.
आपल्याकडे तर पुण्यात उघडलं
जास्त ट्रॅव्हल करणारे लोक असतात ना तिथेच ते ओपन करतात. तो जास्त ट्रॅव्हल करतो ना म्हणून तिथे
सुरू करतात.
Okay. So good evening and thank you once again, Dr. Praveen Patil, Dr. Nilesh Patil, and Dr. Nachiket. Okay. So first of all, let me clarify. I don't carry the notion that I was cut short. There was some confusion. The second thing is I definitely overshoot in MRI con. I possibly will not do here because I'm trying to keep it very, very simple and brief. Dr. Praveen has already told me that keep it little brief, don't go into details. So I'm going to have just brief introduction. Largely, slides will act as a skeleton on which we can discuss whatever the points we want to clarify. So this is more to insight discussion and clarify things rather than to try and teach something. Okay, so next slide. So first of all, what comes to our mind when we read, listen, or say PFT? Okay, good. You are definitely one with focus. Yes. Mm. Objectivity. Yes. Anything else? Pathophysiology of airway versus parenchyma. Yes. Anything else? Disease monitoring. Yes. Okay. So, yes. Just finish. Okay. So next slide, please. So this is what is also a part of part and parcel of the things. The graphs which are not interpretable easily, most of the times, 90% of the times, and the numbers which are lot many, we don't know how to make sense out of these. So I'm not going to run you through the process of how to make sense of these numbers, but how to identify the key ones, as Dr. Nilesh said about the FVC is the only one number if you have to take away from the today's talk, which is most commonly available and most robust one. Next. However, when I see PFT, I say PFT, this is what all comes into my mind, and I have to be sort of wary of all these things. I'll not bore you with all these things. Next. So once we are organized little bit, these are the things which we can actually take help of making decision. And the ones on the left side are of major concern. The on the right side are largely, you can say, useful for very niche areas and are not the topic of discussion today. Next. So today we'll be discussing these three tests: 6-minute walk test, pyrometry, and gas diffusion. Only interpretation, I'll skip the conduct and validation of the study. Though that is very, very important, interpretation actually starts with the validation of the study. Unless the study is validated by the reporter, you should not move forward. Next. So the first and foremost thing is in 6-minute walk test is how much is the distance. It represents a cardiorespiratory reserve. Healthy adults usually walk around 500 to 600 meters in 6 minutes. Height, weight, and age affect the distance. And of course, in your patient population, the musculoskeletal comorbidities will definitely affect. So we'll have to take into consideration that unless there are, if there are no musculoskeletal comorbidities which limit the ambulation of the patient, this is very good test. If that is there, then possibly this test is not very good test for that particular patient. Minimum clinically important difference is different for different diseases from different studies from different localities. This data is getting standardized eventually with collaborative research. These numbers will possibly get uniform and which are getting uniform for some of the parameters. And as I said, it is affected by musculoskeletal anomalies. Next. Second important parameter in interpretation is desaturation. Anything which is more than 3 or 4% desaturation is considered significant. No matter how strenuous exercise you do, you usually do not drop your saturation. On the contrary, saturation improves in normal circumstances. If the saturation is dropping by more than 3% or 4%, that is clinically significant. Higher the desaturation, more severe is the impairment of gas transfer. And if distance walked is more than 500 meters without significant desaturation, practically it rules out significant cardiorespiratory limitations for the patient to be symptomatic. If patient is complaining of lot of symptoms and this is the test which you are getting, then the only additional thing which possibly you will have to look for is whether the target heart rate is achieved or not. And if that is achieved, then possibly cardiorespiratory limitation is not there. If distance is less than 400 without significant desaturation and still patient is symptomatic, Then we'll have to look for musculoskeletal issues, poor motivation on the part of patients. Sometimes airway diseases can present with breathlessness or discomfort, which is out of proportion to the physiological parameter change, especially the desaturation. So airway disease usually do not develop desaturation. Next. Bohr dyspnea scale is the third important parameter which is taken into consideration. However, it is again very subjective, depends on person to person, how you ask those questions. The questionnaire are not validated in Indian languages, so I tend to skip this one. Next. So just to take home from the 6-minute walk test, it is a simple and easy to perform test, easy to understand and interpret, reliable for serial monitoring. Anywhere it can be done. What it requires is only 30 meters ramp or corridor with a stopwatch and a pulse oximeter, and of course little bit of training for the person who is going to conduct. Moreover, there are some automated devices which come for conducting 6-minute walk test. If you start using that is going to be very easy. I will skip the minimal clinically important difference. However, more than 50 meters change should alarm you for clinical significant change in the underlying condition of the patient. Next. Next. Okay, so moving on to the next important test, which is spirometry. It is also known as the forced expiratory maneuver or FVC maneuver, as you rightly said. Large number of values are there on the report which I showed you. Only 3 are most repeatable and robust, so we should focus on only these 3. So I have made it a point to include only these 3 in my report. I have practically removed all other values from the report. Only other values which are there in the report I'll show you subsequently are to validate the results and not to interpret beyond that. There are other reasons to do that also, but I'll not go into details of that for now. So the FV1, FVC and the ratio thereof is the most, these are the 3 important parameters. Next. This is a video I wanted you to show how to make you understand what is the obstruction and what is the restriction. The video just shows that there is a balloon. The person is trying to inflate a balloon. At normal volume, the force required to inflate a balloon is minuscule. At highest capacity, the force required to inflate the balloon is high, and at the same time, the balloon is pinched at the neck so that it mimics obstructive physiology. So the expiration is prolonged and the person requires a lot of effort to breathe. That is usually representative of hyperinflation. And the third scenario is the balloon is covered around by 2 or 3 rubber bands, additional rubber bands, which acts as a restriction. So this again increases the work of breathing, but in different way. So the force required to inflate a balloon even at the smaller size is increased. That is what the physiology which most of you are going to deal with, in whether it is in terms of the skeletal abnormalities, in terms of kyphoscoliosis, or in terms of ankylosing spondylosis, or in terms of restrictive disease secondary to interstitial lung disease, pulmonary edema, pleural effusions, or pleural fibrosis secondary to advanced disease. Next slide, please. So these are the graphs to validate the study. The first one I suggest you of a normal. The first and foremost thing is to look at whether the expiratory time is adequate or not. Nowadays, they recommend 15 seconds of forced expiratory time for the study to be valid. If that is not being achieved, the other second parameter which they are considering, at least 3 seconds of plateau should be there. If the 3 seconds plateau is not there, the forced expiratory maneuver is not valid and adequate, and at least 2 such repeatable maneuvers should be there for each test. Then come to the left side. On the right side is the volume time graph. On the left side, it is the flow volume loop. So the flow increases, then it decreases slowly towards the end, and then the inspiratory flow is almost the same, is usually uniform. So you have that gray shade. If the curve falls within that gray shade, it is practically normal. You don't even have to look at the values. If these 2 things are okay, possibly you can skip looking at the values also or interpretation also. The next slide. So this is something which is suggestive of significant obstruction, wherein the flows pre and post volume time graphs are separated by significant volume. suggesting there is significant bronchodilate reversibility. The plateau has not been achieved. Almost 9 seconds is the blow time for both pre as well as post. In the second graph, there is some plateau for around 6 to 8. So 2 seconds plateau is there. And in the first, around again 6 to 8, 2 seconds plateau is there. But this graph is suggestive of obstruction and there is significant bronchodilate reversibility. And the graphs you can see are showing some cooling on the expiratory side. Next. And this is something which is classically suggestive of restrictive physiology, where the expiratory curve is relatively smooth and comes back rapidly, doesn't pull through very long. As compared to the second one, where it is not very tall. It is going only up to 2, but it is then going very long in time. However, in the first one, it is stopping even at 1.5 seconds. Next. And finally, this is something which is mixed, where the flows are reaching high and then reaching the bottom again very fast. But there is some cooling at the end of it. So these are all graphs suggestive of normal, obstruction, restriction, pure restriction, and this is the mixed effect with some component of obstruction. Next. So this is again a depiction of how to interpret these graphs: normal, obstruction, and restriction. Restriction is in the blue. Next. This is new way. All of you are actually used to it much before us in terms of osteoporosis, Z score, and lower limit of normal and Z score. This is how the values are getting standardized, and possibly few years down the line, we'll stop getting reports in terms of percent predicted and all. We'll get reports more in terms of Z scores. Next. And this is interpretation if you actually want to interpret looking at the values. So FEV1 by FVC ratio is the first thing to look at if it is normal, which is more than 70% as per the older criteria, or lower limit of normal as per the older criteria. Next, please. Next. Just wait. Now it is replaced by standard error of estimate. Now, if it is less than minus 1.65, if it is more than more than minus 1.65 standard error of estimate, it is considered normal. If it is less than minus 1.165 standard error of estimate, it is considered as low or lower limit of normal for that particular individual. Then you have FVC, which is normal. Then it is reported as normal. If FVC is reduced, then it is suggestive of restrictive defect. If your FU1 FVC ratio is less than minus 1.65 standard error of estimate, or we can simply call Z score, then if FVC is normal, then it is normal, OAD, mild or moderate. And if it is reduced, if FVC is reduced with low ratio, then you may have either mixed defect or it could be a severe obstruction wherein the patient is not able to achieve expiratory post-vital capacity completely. We have to do additional testing. So again, I'll not go into the additional testing at this moment. I'll touch to that little later. Next slide, please. So severity grading again previously was based on percent predicted. Now they are recommending severity grading based on standard error of estimate or Z score. 1.65 to minus 2.5 is mild, minus 2.51 to minus 4 is moderate, and less than minus 4 is severe impairment. And this is common for all. Previously it was different for FEV1, different for FVC, different for obstruction, different for restriction, different for asthma, different for COPD. So all had different grading. Now they are trying to uniform it. Next. So severity grading, putting things into context, severity of the defect does not correlate with symptoms. FEV1 correlated better with symptoms than FVC. So if at all you want to grade the severity, it is better graded based on FEV1, because most of us breathe for 1 second or less than that. We don't breathe for 2 seconds or 3 seconds. So FVC is not going to be a reliable marker of severity or symptoms. Serial measurements give better idea about the behavior of the underlying pathology, and this is the main crux of your interpretation, what you're going to see and focus upon. Next. So one of our patient had spirometry. FU1 FVC ratio is 68%. Z score is minus 2. FU1 is 3.44, which is 112. Which is Z score will come onto the positive side. So I have reported it as a mild obstruction with significant bronchodilator reversibility. Is this interpretation correct? Can you make something out of it? Mm-hmm. So, mm-hmm. Mm-hmm. Yes, sir. Mm-hmm. Mm-hmm. Yes, definitely. So basically, it is objective measurement of what exactly we are dealing with. So if you have a patient who has full blown CTD for which he or she is on regular treatment and comes with this report, this is completely unrelated to CTD. None of the CTD related obstructive physiologies are reversible. If it is reversible, then it is not related to CTD. If it is not reversible and still obstruction, then it can still be part of CTD, bronchiolitis or bronchiectasis, which usually are not reversible. But if something is reversible, it is not part of CTD. It is a completely separate disease, most likely asthma. So the crux here is for obstructive defect, the ratio is most important. FU1 FVC ratio, if less than lower limit of normal, that quantifies for obstruction, even if the FU1 or FVC is more than 100% or 130%, 140%. So there are patients who have 130%, 140% of FU1 and FVC, but still they have symptomatic, still they have wheezing, and they are better with treatment for asthma. So many times we get a question or query with these reports, values are more than 100%, and why are you saying obstruction? So that is the one reason why I had kept this particular tricky scenario here. Just to clarify that in restriction, you need it less than 90% at least to call very mild obstruction. 80% to 65%, 65 to 80 is called mild. 80 to 90 is very mild. Then 65 to 50 is called moderate to severe. There are 5 categories actually, but again, it doesn't correlate, so we don't go into details of that. So next. Normal FV1 to FVC ratio, if you are to take a fixed ratio less than 0.7 or 70% is considered abnormal. More than 70 is considered normal, but it is again age dependent. For patients less than 40, more than 70 also could be abnormal. For patient in 80s, even 65 could be normal. So we have to go by the lower limit of normal, which is coming up now. The newer equations, which is Global Lung Initiative equation, which has got only 4 categories: North American, European, Northeast Asian, and Southeast Asian, and then mixed, which is not covered in these 4. So mixed is actually average of these 4. So if you so we largely will be using mixed equation now for Indian population as well as for global population. So that will take into consideration a lot of variability, and the lower limit of normal possibly will become a norm at least in next 5 years, because these guidelines have been published just 2 months back. Till 2 months back, the things were completely different. Yes, sir. Mm-hmm. 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 Unfortunately, pulmonary function testing, any of these pulmonary function testing which I have listed, the entire boxes, they do not give any idea about what is etiology. They can only give what is the physiological status of the airways, what is physiological status of the lung parenchyma, what is physiological status of the respiratory membrane, which is gas transfer, what is the physiological status of the pleura possibly, or extrathoracic, extrapulmonary component. They do not give anything about etiology per se. It won't. It won't. Mm-hmm. Mm-hmm. Yes, definitely. But for etiology, we have to look for other parameters. What we are trying to look at here is whether the physiological abnormalities are congruent with the symptoms or the clinical manifestations or not. No, no. Only thing which I said regarding Sjogren's is yes, reversibility. Bronchiolitis is largely not reversible. One, small airway dysfunction is the second thing, which usually will not be picked on FVC maneuver. You will need something called body plethysmography for that, or you will need impulse oscillometry to document that. One of these two, which can look at the airway resistance specifically. We don't test airway resistance in these tests. So neither spirometry or gas diffusion, DLCO, which I'm going to cover next, they will not cover. Asthma, yes. Yes. Yes, yes. Okay. So, okay. Next slide, please. We are done with this. So, bronchodilatory reversibility criteria also had changed. I don't think, okay, but just we discussed how to differentiate whether it is immune mediated or not immune mediated. So, previously the criteria was 200 ml and 12% of the baseline value. Baseline value means pre-bronchodilator value. The percent change or absolute change. Percent and absolute change. More than 212% was required either in FEV1 or FVC to say that it is reversible. This is also changed now. Now they are saying more than 10% of the predicted value for the patient. So which is irrespective of the baseline value. So a patient may have say 30% of the predicted value. 10% of that will be very small amount in absolute terms. So to get away that absolute number, they have come up with a more reliable, more widely practicable number, more than 10% of predicted value, either FEV1 or FVC. So these changes, all of us will have to make into the software to get these values reflected in the report in next 3 to 6 months. Otherwise, we'll get confused. We cannot interpret the older report as per the newer guidelines, because the calculation which goes behind calculating these numbers has to change in the software. Next. Predicted value, ethnicity, height, gender. More to sex than gender. That is also specific. So biological sex is considered as more reliable than gender. So these are the three. Yes. Hmm. Yes, age. Okay. So F1 FVC, whether it is normal or increased, is of concern to you. When it is decreased, possibly you will say, you will remember the chest physician. You will not try to go beyond that. Absolute value of FVC is something which is gold for you from spirometry. You will have to document and possibly monitor serially. The only caveat here is that you have to ensure that the FVC maneuver is performed nicely by the patient. If they are not able to perform, there is no point trying to document those values which have no meaning. So if force security time is 1.5 seconds, 1.2 seconds to hardly 2 seconds, 3 seconds, and patient has coughed even during that time, those FVC values, if you document, you are likely to grossly overestimate the severity of physiological impairment. So if you ask me, more than 80% of the spirometries come into that category where I cannot document anything. Percent predicted FVC or Z score of FVC is something which you may consider for initial severity grading. However, once patient is on regular follow, you will possibly go by more by absolute values, trend over period of time, which I'll show you in one of the case. FVC change over time, more than 10% decline is suggestive of progressive fibrosis. Even this is changing now. More than 5% also is being considered significant. The reason for that is the goal is to intervene early. So that if you lose already 10%, or if in an attempt to document 10% progression, if you lose 6 months to 1 year's time, possibly you are losing out on significant lung function. This 10% decline is over 1 year. But if it is happening less than 3 months also, it is still significant. But if it is happening more than 1 year, then you will have to take the entire picture into consideration, whether it is part of normal aging or not. So two spirometries taken 5 years apart and more than 10% progression, possibly we cannot interpret that. Anything less than 1 year, if it is progression more than 5%, we can still consider. Again, for that, possibly it is better idea to document it on 2 occasions. Progression. So baseline value 1, after 3 months or 6 months, if you get 10% progression or 5% progression, repeat the next one in less than 1 month's time, or 1 month or 2 months time, and see whether that is also consistently showing the same trend or not. If that has reversed by that time already, then you don't need to act. But if it is not reversed by that time, then possibly yes, we can.
How frequently would you advise consuming tests in
Depends on which pulmonary function test. Pyrometry, so 6 minute walk test is something which can be repeated more frequently. Initially, at the time of diagnosis, I usually tend to get 6 minute walk test once on therapy every 4 weeks or every follow. Definitely, because the measurements will not be validated at home. Distance will not be validated. Exertional desaturation also will not be validated. They will not conduct in the same manner as it is conducted in hospital. So preferably it should be done at the same setting where it was done at baseline. So in fact, even for spirometry, that is the same applicable, because the equation which is used may be different for different laboratory. So for one equation, you may get percentage predicted, which is 90% for the same value, and the other laboratory may report the same value. The FVC is same, but the percent predicted is different, say 110. There can be a difference of 20-25% that way. So that is why I said, if the patient, once the patient is on regular follow-up with you, you possibly will believe more into absolute FVC than anything else. So that is the only thing which you may focus. At the beginning of the diagnosis, you may take a look at everything, but subsequently you may just look at absolute value of FVC, primarily for interstitial lung diseases. So FVC, yes sir? Huh? Absolute cutoff, no, there is no absolute cutoff. Cutoff is either Z score or percentage predicted, because it depends on the race, sex, height, and little bit difference by weight, not much affected by weight. Nowadays they are coming, ma'am. So it depends on which company we are using. The latest one, all are, especially if you are using Global Lung Initiative equation, then the Z score is there. If you are looking for bronchodilator reversibility, which usually you are trying to look at the time of diagnosis, so preferably try to stop bronchodilator to the patient at least 2 half-lives before the performing test. So if something which is effective for 12 hours, at least 24 hours before you have to stop. If something is effective for 24 hours, 2 days before the spirometry, you have to stop. That is largely if you are trying to look for bronchodilator reversibility. For somebody who is already on treatment for asthma and you are interested only in absolute change in FVC over time, as far as associated interstitial lung disease goes, then possibly you need not stop them bronchodilators. And in fact, you may ask for only either post bronchodilator test or test without bronchodilator. Restrictive lung diseases, it doesn't matter. Bronchodilator reversibility is not part of restrictive lung disease evaluation. This is largely to look for obstructive lung diseases. Okay. Next. So the third important test is gas diffusion test, which is commonly known as DLCO, diffusion capacity for carbon monoxide. The carbon monoxide is chosen because there is no competitor from the blood side for the carbon monoxide. Whatever is the flow is happening, it is happening one way, and it is easy, and it is the one which transfers fast. So it is a measure of respiratory membrane function, always performed and interpreted with spirometry and preferably lung volumes. However, because of the limited availability of the body plethysmography, lung volumes are not done routinely, and we have to sort of accept that handicap for most of our clinical practice. Next. This is little more detailed algorithm for interpretation when you want to interpret in terms of DLCO. However, if I try to go into the details of it, it is going to just worsen the complexity of it and possibly going to hamper the take home. So we'll just stick to the fact that gas diffusion is something which is very, very sensitive marker of interstitial lung disease or alveolar membrane function. It can be affected by interstitial pathology, alveolar pathology, or pulmonary vasculature. These are the three important pathologies which affect it. So any of the three compartments we are looking at will come to know. If it is pulmonary edema, it will be decreased. If it is diffuse alveolar hemorrhage, it will be increased, which is classically used as a test for a hypoxic patient with increased DLCO. Largely, the diagnosis is diffuse alveolar hemorrhage or alveolar hemorrhage. Yes, because the blood which is there in the alveoli will catch all the carbon monoxide. So the return will be less. So the calculation is based on the amount of carbon monoxide which is inhaled versus which is coming out. So if there is lot of blood available in the alveoli, that will sort of bind to carbon monoxide which is going there. So it will overestimate. So DLCO will be spuriously increased in alveolar hemorrhage. But to be very frank, I have not seen a patient of DAH coming for DLCO. Most of them are not in a condition to do DLCO. They are hypoxic and they are, so these are all theoretical tests for discussion. Yes, yes. We are doing, in Pune, we have 4 or 5 centers which are doing DLCO. Pulmonary hypertension. Charges are variable, but complete lung function test comes somewhere around 5,000, 5 to 6,000. Exactly like spirometry, the patient has to basically breathe out completely, then patient has to breathe in. I think I'll come to the graphs. When I come to the graphs, just remind me, I'll show you how it is performed. Because it will become more complex, I have skipped the steps of performance and validation. Okay, so next. So these are the 2-3 important things where DLCO will be decreased, pulmonary hypertension and this thing. Next. Yes, sir. Mm-hmm. Mm-hmm. DLCO is low. The patient can have interstitial lung disease. FV1, FVC is normal in interstitial lung disease. Yes. FVC can be normal. In alveolitis, you can have FVC which is normal. No, so that is what I'm trying to equate, trying to clarify. Low DLCO does not equate to pulmonary hypertension. Low DLCO can be because of pulmonary edema. Low DLCO can be because of fibrosis, pulmonary fibrosis. Low DLCO can be because of alveolitis, so interstitial inflammation of any cause. Normal PFT means normal FVC, you are saying. FVC is normal. So very early interstitial lung disease can have normal FVC. Low DLCO. That is why it is the most sensitive marker of respiratory membrane function. Respiratory membrane includes alveolar epithelium, interstitium, endothelial, pulmonary capillaries. So the interface between the alveolar epithelium to the endothelium, this is the respiratory membrane. Normally, this is very thin and occupied only by some amount of interstitial fluid, very thin streak of interstitial fluid. Practically, RBCs are coming directly in contact with the alveolar gases, separated by a very thin membrane. So if there is any impairment in that respiratory membrane, DLCO can be low. But again, any sensitive test is fraught with the problems of conduct. If there are any problems in conduct of the test, then you are bound to have wrong readings. Mhm. Wrongly conducted test is 1. Leaks in the circuit is 2. Other than that, false positive low DLCO, I don't see any. Only other things which you can think of is something like carbon monoxide poisoning. Already the hemoglobin is so much bound with the carbon monoxide that it cannot take. So there is the very basic principle because of which we are using carbon monoxide as a gas for testing will be defeated if the carbon monoxide is already there. A very high level of carbon monoxide is there in the blood already. Yes. So pulmonary hypertension and early interstitial lung disease. These are the two causes which will you will have to look very carefully for that. CT scan should help to detect early interstitial lung disease, but sometimes it doesn't. We'll discuss that case where we had absolutely normal CT with lot of abnormalities. So again, CTPA will only rule out pulmonary embolism. It will not give us any additional information about parenchyma. See, cardiac catheterization, one of the important problem with cardiac catheterization is there are very few people who are actually interested and experienced in doing cardiac catheterization. Mhm. No. Ask for DLCO. Anybody who has suspicion of interstitial lung disease, at baseline at least once you should ask for DLCO. Yes, spirometry with DLCO is what you should be asking for. And if it is absolutely normal, you may not repeat it. If there is no suspicion of interstitial lung disease, if you found other cause for breathlessness treated appropriately, you may not monitor it. But if you have any suspicion that there is associated interstitial lung disease along with for this particular patient, and if the baseline values are relatively on lower side, mild, moderate, severe, whatever reduction, then at least every year I think you should ask 6 monthly for initial 1 year for at least FVC and yearly for gas diffusion. Gas diffusion you may ask more frequently if you really are looking for improvement with treatment. Clinical symptoms and CT. DLCO usually improves with treatment if it is the interstitial lung disease is detected at early stage, like alveolitis stage, where you are having lot of ground glassing, and then you treat it, lung parenchyma becomes normal, DLCO improve. But if it doesn't improve, then you are possibly looking at fibrotic component of it, which may not improve. Still in that case, it is better to document because subsequently for listing and all, transplant listing, that becomes important criteria. Antifibrotics is the next topic we'll discuss there. What to expect from antifibrotics? Okay. Okay. So these are the graphs once again. Sorry. So this is normal spirometry, the same graph which I showed as a normal. You can see the Z score. Values are well within the range. So we'll skip this. Next. Go back. The one on the right side, shaded. Next slide. Okay. So this is the graph. Ideally, this is how it should look like. If you are having any problems in this graph, this is 10-second hold, and this is where is it? Can you just move it? . Okay, so this is the 10 seconds hold. If there is any problem in that graph, then you don't have valid results. If you really want to have valid results, that graph should look nicely. At least 8 seconds should be the breath hold time. If there is no 8-second breath hold time, then this is not valid. So that is what you had been asking. And see, these are the values normal for the same patient. Next. So this is obstruction. Next, we'll skip this. This is a patient with antisynthetase syndrome with interstitial lung disease as a predominant presentation, and he has been on follow for 2 years now, doing fine. So his lung function is almost stable for last 1.5 years. Next. So this is his DLCO, 53%. He is hovering around 50 to 60% for last 1.5 years. Next. Next, we'll skip this. Next. Hmm. Hmm. I think I have kept that slide. Next, नहीं इसके पहले चले जाओ. पीछे 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 पीछे. Go back, go back, go back. I think in discussion we skipped that slide. Go back, go back, go back, go back, go back, go back. This is next. Go back. This is KCO is nothing but DLCO divided by alveolar volume or alveolar ventilation. So normally, if it is predominantly fibrotic pathology, so some of the alveoli are cut off. Ventilation is also not going there, and the perfusion is also not going there. It should not affect your DLCO largely, or if at all it affects, DLCO and KCO should go hand in hand. So if there is 60% reduction in DLCO, the KCO also should be 60%. So the ratio actually will be normal. So KCO will be in normal range because the loss is synchronous with the volume loss. If the loss is disproportionate to the volume loss or alveolar ventilation loss, which usually happens in pulmonary hypertension. So there is additional component of pulmonary hypertension. Whenever you have a restrictive physiology also, DLCO is also decreased, but KCO is decreased out of proportion to the DLCO. Then you have two possibilities there. One is either there is superadded pulmonary hypertension, or there is some component in lung parenchyma which is at the phase of alveolitis, where the ventilation is good, ventilation is there, but the gas transfer is not good. So those are the patients where it is likely to be have reversible potential. So KCO reduction, which is out of proportion to DLCO, impairment over and above the volume loss, usually seen in vascular pathologies or presence of alveolitis. So these are the patients where we will have to look more carefully for additional causes. If KCO is towards normal and DLCO is decreased, possibly we are looking at more of fibrotic component and no additional pulmonary vascular component. Then they most probably have pulmonary hypertension, but that usually is not the case. Usually KCO is towards normal side. KCO is preserved, DLCO is decreased in CTD ILDs. Yes. Yes, yes, yes. Because alveolar ventilation there is normal. So DLCO can be. However, pulmonary hypertension usually is not missed on echo unless echo is performed properly. That is what I said. Unless there is a caveat, unless the echo is performed. So I know I have gone into the depth of this topic to such an extent that I have even thought of doing right heart catheterization myself. Forget echo. So having a echo machine in pulmonology OPD, doing echo on myself, doing right heart catheterization on myself, all these things I have thought of, but eventually it's not possible. Exactly. So pulmonary hypertension clinics are run by pulmonologists as well as cardiologists. Those who are clearly interested in pulmonary hypertension, they are the ones who can actually do catheterization better. So if you really want to work up a patient for pulmonary hypertension, Narayana Hridayalaya Bangalore is a better option. Send patients there for evaluation. They'll do right at catheterization. They have a team of cardiologists, cardiothoracic surgeon, transplant pulmonologist, and a pulmonologist who is interested in pulmonary hypertension. Dr. Basha Khan and Dr. Syed and Dr. Murli Mohan. These are the three pulmonologists who work on that. Dr. Basha Khan is the one who has keen interest in transplant as well as right heart catheterization. And they have a tie-up with specific 2 or 3 cardiologists who will be having MDD with them. Okay, so we move to the next. Keep going, keep going, keep going, keep going, keep going. Okay, go back. So how do we use them in rheumatology practice? All this. So this is Dr. Nilesh's patient. So she is 27-year-old female. In 2006, she had psoriasis. 2018, she had been diagnosed with SLE, fever, musculoskeletal, and hematological involvement. Antibody profile was this. In 2020, she was off steroids for about 6 months. In May, she presented with breathlessness class 3, class 4 at that point in time. CT chest showed very minimal features of NSIP in right lower lobe, which frankly I couldn't even appreciate even after multiple reviews. Next. Spirometry was not 6-minute walk test was not done at baseline because she was not willing to, or she could not do it. Spirometry was done, which showed mixed defect, no bronchodilator reversibility. FV1 was 42%, FVC was 1.1, 45%. Gas diffusion at that point in time was 44%, and KCO was 1.26, which is 64%. So you can see here 3.01, 44%, and KCO is 1.26, 64%, clearly indicating that there is no over and above additional component in terms of pulmonary vasculature. Functional impairment out of proportion to radiological involvement. So she was treated as acute interstitial lung disease at that point in time, with which she showed improvement. Next slide. Follow-up after 1 month, she is symptomatically better. 6-minute walk test, she did not even drop her saturation. Spirometry, however, showed improvement. Both FE1 as well as FVC, and gas diffusion was not repeated at this point in time. Next. And this is 21, she remained asymptomatic. In September 22, last month, she presented again with breathlessness, class 4 CT, and once again did not show any convincing evidence of ILD. No pulmonary embolism. CTPA was done this time. 6-minute walk test is not even desaturation. Even now, spirometry does not. Spirometry though showed some worsening again as compared to her new baseline, which was after 1 month of treatment, and after 1 year of treatment also it was almost the same. In September 21. So after one and a half year of treatment, she had FE1 of 1.47, FVC of 1.65, and finally now she has FE1 of 1.15 and FVC of 1.26. So there is some progression, and in gas diffusion also there is some progression, some worsening. So you can see the gas diffusion which had improved after 1 year, it is dropping again. So all the parameters do show improvement only if the disease is treated very early in the phase. Once the fibrosis develops, it doesn't show any improvement. Next. So this was all about spirometry. Briefly, we'll go to antifibrotics and then I'll ask question. In antifibrotics, I'm not going to go into the details of studies. I'm just going to again use them as a skeleton. But I'll start with the question which Madam had asked. With antifibrotics, the only expectation is to slow down progression, not even stop progression. There is no expectation in terms of improvement in any parameters, be it symptoms, be it lung function, be it gas diffusion abnormalities. So all the things are only slow down. No. So I have an interesting question. What do you think is the best antifibrotic or strongest antifibrotic you have? The class of drugs. Yes, immunomodulators. So you all are best antifibrotics for the patients. best way is to prevent the fibrosis from setting in. If you hit at the immunological phase itself or inflammatory phase itself, you don't even need those drugs where you can expect only slowing the progression of the disease. So if most of the interstitial lung diseases which we see today are actually immunomodulation responsive, from the two Indian registries, one is all across India and the second one a single center experience from PGI. Both of them suggested that sarcoidosis, hypersensitivity pneumonitis, and CTD-ILD combined together, they form more than 75% of interstitial lung disease patients. So if more than 75% of interstitial lung disease patients are actually responsive or amenable for early intervention and prevention of development of fibrosis or completely reversible, possibly, then I think that is the largest group where we should focus more on. So the early appropriate diagnosis and appropriate treatment should be the goal for all ILDs. Next slide, please. So this we already covered. Next. Okay, so these are the trials in pirfenidone in IPF. There are three trials: Capacity 1, Capacity 2, and then Ascent trial, based on which the pirfenidone was approved in 2014 in US, and in Europe it was approved in 2011. Then next, Nintedanib trials. There are three trials again. Tomorrow trial was in 2010-11. It was phase 2 trial, and Impulses 1 and 2 were published in 2014. And based on that, 2015 guideline included both drugs. So till 2015, there was no approved treatment for idiopathic pulmonary fibrosis. 2015 was the first guideline where there was some treatment. So till that time, the IPF guidelines were labeled as no treatment guidelines. No to all treatments. They always said weak no, strong no to all the treatments listed. There was no treatment where it was said yes or consider. Before 2015, there was no guideline. There was evidence from the Japanese studies from 2007-2008, but it was not in the guidelines. 2011 guidelines did not have anything to suggest positive treatment. 2015 guidelines was the first where they said there is something to offer, and these are the only two drugs now. So next, combining these together again has been tried in two studies, but combining them does not have any added benefit, though they are safe. Doesn't affect each other's pharmacokinetics. So they have studied pharmacokinetics, they have studied side effect profiles, but there is no added efficacy yet. So we are awaiting larger trials for the combination therapies, and I'm sure pharma will surely push for that, and then they'll come up with dual therapy, triple therapy trials like pulmonary hypertension. So that is eventuality. Next. So, so there is no debate. Antifibrotics are there to stay, at least for IPF treatment. Two drugs available. Both are equally effective. Side effect profile for both drugs has significant overlap. No benefit of combining both together at present. And there is not the, this is not the forum to discuss in detail. So we'll not go into details of that. Next. So coming to the most important disease which we are interested today is systemic sclerosis. This is the largest trial for systemic sclerosis where nintedanib has been studied. And it found that almost 50% reduction in yearly loss of FVC. So 100 ml, roughly 90 to 100 ml was the loss in placebo group, and the loss, yearly loss of FVC was around 50 ml in nintedanib arm. So there was almost 50% reduction. So for 50% decrease in FVC report, will you recommend a drug for 1 year for a patient of systemic sclerosis at the age of say 30-31 year of diagnosis? So age at diagnosis is 31 years. Patient has FVC today of 1.70 liters. And next year she is going to come to you with result of 1.60. If you don't give nintedanib and 1.65, the percentage will vary. If her baseline FVC is say 0.7, it is say 50 ml is going to be more than 10%. If it is baseline is 1.8, the percentage is going to be less than 5%. Yes. So the second question is, the longest study which is available to us is extension arm of these trials for 2 years. There is no data beyond 2.5 years. So there is some extension arm data available from IPF trials. but not in systemic sclerosis. In this trial, almost 50% of the patients were also on mycophenolate. Not much difference. Not affected by mycophenolate. Yes. Yes, second. Yes. Secondary endpoint. So all these symptoms were not there because 50 ml, as I told you, lung function does not correlate with the symptoms. Mm-hmm. Much better, yes, because the rapidity with which the lung function loss is there is much more in IPF. If you compare the placebo group functional loss in some of the IPF trials, it was 250 ml when the trials were started at the later stage. When the trials were started at earlier stage, the function loss, yearly function loss, FEC loss in IPF was 100 to 150. In this trial, it was 100. Definitely, yes. That is why the question. So if we have a strongest antifibrotic effective for systemic sclerosis, possibly holding back nintedanib makes a sense. But if you are not yet convinced about the strongest antifibrotic, which I was talking about, which is immunomodulation, which is eventually likely to fail and patient is going to need additional support, then possibly it is better to start as early as possible, because this trial also did not require the patient to have a documented progressive disease. So irrespective of the progression, because systemic sclerosis by definition is still a progressive disease, it doesn't need to be documented that you need to have a progressive lung function decline in that disease. For all other diseases other than IPF and systemic sclerosis, they said. Mm-hmm. Mm-hmm. Okay. Mm-hmm. Fine. So then that opens the topic even more. Should we really be considering nintedanib? See, the problem there is that once you have lost a significant amount of lung function, there is no going back. It doesn't help at all. It doesn't reverse anything. Mhm. No. We are not talking about CTD ILDs, all CTD ILDs. I'm not saying that any CTD ILD, the diagnosis, you should have antifibrotics. I'm strongly against that. Despite such a wonderful trial, which is largely conducted, I'm still not convinced whether we should really be considering nintedanib. But the only thing which makes me think about nintedanib for very selected group of patients is because one, they are very young patients. They have decades to live in front of them. Monitoring is very difficult for them. They are not able to perform spirometry and all these tests most of the times. And finally, once the lung function is lost, it cannot be recovered. If disease is something which is slowly progressive, why not pirfenidone? No, but why not pirfenidone? Not all. You are talking about systemic sclerosis or other diseases also. No, all CTDs we cannot. Scleroderma we can discuss. Other diseases, because the disease is variable, fluctuating. You have to identify the activity and treat accordingly. Can consider only for scleroderma. I would say for somebody who has already lost a significant amount of lung function, if see, we cannot go by any of the cutoffs. Reason being, they have not been studied. No, no. CTs. So 10 inclusion criteria was more than 10% lung fibrosis at baseline. Yes, on CT. But again, CT doesn't correlate with severity of symptoms. Yes, it was inclusion criteria. Exactly same is my question to all of you. Mhm. Because see, the biological behavior of disease, you people know better than me. So if I look at this evidence and if I see a patient in 30s who has at least say 20-25 years to live, and even if I save say 50 ml every year, in 10 years I'm going to save 500 ml of her lung function. 500 ml of FVC loss prevention over 5 years is wonderful for me. I can consider that. But for that, the patient has to take drug for 5 years, on regular basis. Ah, okay. Okay. So from diagnosis till 5 years or 7 years, whatever. Do you have any markers for saying whether it is still progressing other than lung function?
But the chances, like, so there are two types. The chances of developing ILD is okay. So most of them, even that see progression and all that happens in the first years.
Mm-hmm.
Then ILD is usually progressive in initial 5 years, and it plateaus on most of the time.
And then it stays like that. It doesn't
forever.
continue to
It
progress.
doesn't. No. It is not a forever progressive.
So treating, using even antifibrotics along with immunomodulator therapy for 5 years is good enough. Mm-hmm.
If you have GPOs and you have those cellular NSIP findings,
Mm-hmm.
it is only immunosuppressant.
Mm-hmm.
But if you have those reticular things and fibrotic NSIP, I think I would consider
To me, if somebody can do a very accurate PFT, that is the most important predictor. If the PFT is showing a significant decline in FPC over 6 months, 1 year, or 2 years, so this is a progressive disease. This patient requires antifibrotics lifelong. But if it is showing,
but again, for that patient, you may still be able to get slowdown or halting of disease progression, say after 5 to 7 years, maybe
most
10
patients,
years.
most patients will.
So that may be
patients-
the time when you may actually consider taking it off.
So beyond that, who will need it will all depend on progression. Not all will progress. Very few will progress. There are exceptions to everything.
But if we use it in every, probably we'll bring down the plateau of loss of lung function.
But no, it doesn't happen like that. So antifibrotics will happen at a different stage. That there are immunosuppression will play a role in the initial 5 years. It's the beyond that where slow fibrosis happens. May not be that much of inflammation.
Yes, precisely.
Has to be
Even
identified.
CT findings, as sir
there's
said,
no-
if I look at CTs of patients with systemic sclerosis, largely I cannot differentiate them between active versus inactive.
Correct.
And they look almost the same year after year after
Correct.
year after
So there
year.
is no progression happening.
Even if I say I can remember a patient whose CTs are there from 2013-14, and very nicely conducted CTs, nice images, nicely reported, including segments. They report this segment has got so many of areas of fibrosis and all that. So with all that documentation, still there is no significant
That is typical
sign of
sclero-
activity.
Yeah, that is typical of scleroderma. Very few will progress, but that it's a difficult thing to find out that group which will progress. But most will not.
Most will not progress. So recommending antifibrotics blanket for all patients is something which is against the philosophy. Fine. So that
Many patients they don't tolerate this.
I know they don't all, and even there are no studies beyond 2 years. That is one of the important factor. At least in systemic sclerosis, there are studies, no studies, and whatever the data extension data is available, the same effect was not maintained beyond 1 year. So in the second year, the same effect was not maintained.
Sorry to interrupt. We have 4 minutes. I've been told. Okay, we got to reach.
Let the speaker carry on.
I think it is necessary to invite him once more.
Correct.
And
Discuss on scleroderma, thrash out the scleroderma.
Only scleroderma.
and have
Specific.
have a big discussion once more.
Because fibrosis and inflammation are not exclusive to each other.
Yes,
They are
They go
inclusive of each
together.
other, and probably there's a barter where as the inflammation comes down,
Problem
fibrosis
is,
goes
yeah, it
over.
is disease
So
specific.
probably giving it to everyone might decrease the quantum of lung loss.
that is only basis
Hypothesis though.
possibly consider giving them.
I think the basic question that always arises is that if some patient has RA and some sort of lung disease, are these two related in all patients?
Cause and effect relationship cannot be committed for all patients. But if there is one disease and if there is manifestation which is known for that disease, it is prudent to assume that it is part and parcel of the same disease and treat the same way, rather than trying to make a separate diagnosis for that. Unless it itself has got some strong pointers to suggest that this is unrelated. Otherwise, it is better we assume it is part of the same disease and treat it the same way. Rheumatoid arthritis associated interstitial lung disease is something, and there are number of studies which are going on. Just post a few slides further.
खूप महाग आहे. ती महत्वाची
Next,
गोळी आहे.
next,
नाही, मी बंद करतो.
next. Oh, so these are the trials which are some of which have been completed and some of which are still under control. And these are considered antifibrotics.
ती नाही दिली, research reason नाही दिली, stop करतो.
So there are trials which are going on in rheumatoid arthritis associated interstitial lung disease, and to me it is actually a surprise why systemic sclerosis ILD is so much of a sort of ILD means systemic sclerosis ILD. But why not ILD can be rheumatoid arthritis associated ILD? Because if you look at the incidence and prevalence of rheumatoid versus this thing, systemic sclerosis, and even if you say, I think I had included that data in my Solapur presentation, where effectively rheumatoid arthritis associated interstitial lung disease actually should be the most common interstitial lung disease which you comes in your practice. Much higher than systemic sclerosis associated ILD, and possibly the second one comes with dermatomyositis, and at the third point systemic sclerosis. So why rheumatology research is actually not focusing on these two ILDs and focused more on,
Because it is progressive scleroderma, rapidly progressive, comes early on in the stage of disease. In RA, it comes much later on. In scleroderma, it can come usually earlier.
30% of rheumatoid arthritis associated interstitial lung disease present before rheumatoid arthritis manifestations.
Yeah, that is okay.
70% of the dermatomyositis
But those are
associated
CT
interstitial lung diseases present before manifestations of myositis.
Possibly they are reaching you first rather than us.
They are more fulminant than systemic sclerosis.
Yes,
So the only
again
Wait.
that subset is different because that is lung predominant.
So basically, most
no, I am talking about this. If you consider all rheumatoid arthritis associated or dermatomyositis associated ILD, the only reason which I can anticipate is that it is much difficult to conduct trials when patient is critically ill, and it is much easier to conduct trials when patients visits only to rheumatology clinics. So those patients who are visiting rheumatology clinics only, they sort of get focused and tried more than the diseases which are coming to something like critical care or maybe internal medicine areas, or they are dispersed everywhere, pulmonary critical care, critical care.
Another reason is early scleroderma is almost considered reversible if it hurt. Like we used to give IV cyclophosphamide every 2 weeks or monthly. for these patients.
And
So
usually,
that is still the
RA
practice.
related ILD,
And in,
No, for systemic sclerosis, that is still the practice. If early ILD is the presentation, we still treat them aggressively.
usually RA related ILD is not that progressive and is not the major cause of mortality, usually in our experience, as opposed to
That is the false notion, sir. That is what I am trying to tell you.
Pulmonology literature where they miss RA basically.
Exactly, but that is the false notion.
Like I said, there is one subset.
Mhm.
But 90 to 95% patients with RA, they won't have severe ILD.
they will be coughing.
Because anyways, once we start the treatment, eventually things become all right.
Okay. Whether I have.
It's a referral bias, possibly. The severe ones come to you
first,
milder
and
ones stay with us.
yeah.
Yeah.
And the
Yeah.
milder ones who stay with us tend to respond even to the background musculoskeletal immunomodulation that we give.
Possible. That is quite
So
possible.
the earlier thought that probably
Okay.
methotrexate is unsafe in ILD doesn't hold true.
If Dr. Yenge stands here, we can engage him the whole night. I think
We'll have to.
we will not exploit him so much.
Yeah. Sorry, we have to repeat the MRA thing.
But this time we
promise
ran
you
out
not
of
to
time for
repeat that.
discussion. This time we ran
So
out
this
of
time
time
we
for
are
discussion.
complaining, not he is complaining.
Yeah. That's very well done.
No, it is.
Very rarely we can have this in-depth discussion.
Yes. We'll invite you once more. I think you like the Ramee grant. I don't. They are waiting for us. So we have to head down straight away.
Hello, sir.
Sorry. Please. Thanks to our sponsor. Please go on.
Sir, specially thanks. सगळ्यांनी आल्याबद्दल.
पण आणि सगळ्यात इम्पॉर्टंट पायलोकार्पिन अवेलेबल नाही
हा.
यांच्याकडे आहे.
पायलोकार्पिन अवेलेबल विथ सर द ब्रँड ऑफ जॉगर आहे.
जरा freely available करून द्या.
आहे.
23 rupees per tablet. Again, patient will ask, should I stop?
Okay, thank you, sir. Thank you. Good night. Good night.